Morten Mouvet from US.
Thank you. Thank you to everybody. I have not a specific question, but I'd like to have a comment to the first speaker, to Ingeborg, and then I take in Norwegian. Fordi Ingeborg nevnte to veldig viktige poeng, så jeg tror i hvert fall jeg kommer til å ta meg hjem. Og det er dette her at det er så omfattende det vi er i ferd med å starte nå 1. mars. Selv om vi har vært forberedt på dette i 3-4 år. Men Ingeborg nevnte to sentrale elementer som jeg tror jeg vil i alle fall jeg tar meg hjem. Det ene er bruk så godt du kan dagens arenaer. Og det har vært gjentatt flere ganger. Vi har en god del arenaer hvor vi driver med veiledning og supervisjon. Vi har kanskje ikke like gode som vi kan bli, men vi har arenaene. Og da tror jeg det er lurt å bruke dagens arenaer, de vi kjenner. Og det andre du nevnte er bruk kjente verktøy. At vi kanskje prøver å se litt på det vi har gjort, vi har brukt av verktøy. Altså et verktøy, visitten. La oss gjøre visitten enda bedre, slik at det blir en arena hvor vi kvitterer ut en god del læringsmål. Så jeg kommer til å ta meg dit, Ingeborg. Bruk kjente arenaer og kjente verktøy. Takk.
Just to explain to Joan that what he said, it's you should use what you already know and try to use the opportunities you already have in the old system, and maybe try to continue like that and further on improve it. More questions, comments?
Hello, my name is Knut Harbo, and I'm the head of the department in orthopedic surgery in Stavanger. I've been listening with great interest to your talks, and I have some reflections as I've been taught by Paul Morten to talk about it. And the first is, I have a son that's 12 years old. He likes to play his computer games. And a typical thing with a computer game is that you have to solve some sort of task to be allowed to progress in the game. And just bear in mind that when I talk about the other thing that I like when I try to teach somebody, that I try to divide a specific task into smaller tasks. That you don't always have to do the first bit, you can do the middle bit or the last bit. You haven't mentioned this as much in your talks. Is that still some feasible way to do it, or should you always start from the beginning? I don't like the computer game approach, though.
I like the computer game approach very much, Knut, because it tells us what is important in the new to change. Don't give a doctor task he won't be able to solve. Don't give him the ER call the first day if you don't know his abilities. You should be certain that he could solve the most imminent problems and help him become good enough before you give him the task. And also, I love your way of, and it's also what you're talking about, to have the tasks in like boxes. You do this now first, you get used to this, and then you just, perhaps you assist me, or this will be your task today in advance to explain what do I expect from you today. You will do this part of the surgery today, and then you will assist me. Oh, that's a very nice way of doing it, to lower the stress level in your junior doctor. I don't know if I answered your question, Knut. Yes.
Is it on? Oh, wow. Definitely was. Hi, I'm Dr. Ven from Stavanger. I have a question to the last speaker, or actually more of a comment. You said in the introduction that you, or somewhere in the introduction, that you thought that it was good practice to tell the patients that it was a learning activity, or that someone was taught during the procedure. But at least in the procedure for example, surgery, almost every procedure is a learning procedure where the surgeon doing the procedure is under survey or is being taught. And I don't really see how it's doable to, at every stage during the patient's hospital stay, inform them that this is a learning procedure, that the doctor doing the procedure will be taught by someone more experienced. The patient should assume that when they're in the hospital, there will be teaching involved in the hospital stay, and I don't really agree with you.
Yeah, I understand completely, and it's a very interesting discussion, which we have discussed thoroughly in our courses at Oslo Universitetssykehus as well. I think that the patients have a right to know that there's a teaching situation going on, and I think many people would react if there was any complication or anything, if they didn't know in beforehand that the surgery was a teaching situation. But of course, I don't mean that you need to really go in depth with what's actually going on in the operating room. It's enough to say to present the team of surgeons, and you don't have to go in depth. You can be pragmatic about these things. You can actually alarm the patient and make him uncomfortable, uncertain. And another point I need to address is that actually all the least the junior doctors in Norway are fully authorized, and the patients don't automatically know that. They can believe that it's a med student in the second week. It's important to actually state that the people learning this procedure is fully qualified doctors with a full authorization, so they're not at risk for having a completely incompetent doctor performing on them. And another important point is, as I specified, who's in charge in the situation. That's the more experienced doctor. So as I said, you don't have to explain this in detail before every patient meeting, but I think the patient needs to have a certain knowledge. And I don't know if it is specified in the beforehand sent out information, the written information in the letters before the appointments, if this is a teaching hospital, so you might expect to meet a junior doctor. I don't know if it's specified in the materials as sent out. I don't know. Maybe that would have been enough, but I'm open to discuss that, and I see a point for sure. Yeah. Any comments regarding this? I think it's interesting.
Yeah. Am I turned on?
Yeah.
Can you hear me? So I think in Canada it's a similar approach that letting patients know, yes, when the information that goes out before they come to hospital and when they're in hospital, that it is a teaching hospital, and that they will be taken care of by more junior doctors who are being supervised by senior doctors. So it's not a point with every patient of explaining it unless they ask specifically, but a general statement, as it is important to convey that. Thank you.
Yeah. And when I'm performing as a supervisor in colonoscopy, the patients in Norway are awake. I don't know in Canada if they're awake or sleeping, but then it's very important to inform beforehand, because then we have all this technical talk during the whole procedure. And if the patient is not properly informed beforehand, this can create quite a lot of anxiety. So that's the most important procedures, to actually inform the patient when the patient is awake and experience this whole learning situation, because when many of our patients actually think it's very interesting, and they get a little bit proud when they can participate in the learning of junior doctors. So I think this is a positive thing for most patients, as I experience it. But these might be the most important settings to thoroughly inform the patients.
I can't help myself. The other thing, one thing about the damages to the patients during any part of surgery, because I'm a surgeon, I have reflected surgery part of it. I think the consultants are more than capable of in making the complication themselves. They don't need help from the residents. I do quite a bit of work on the patient's claims, and I can't remember the last 50 cases where a resident was the cause of the complication that ended with a patient claim. So it's important to explain it to the patient so that they feel, as you say, confident that they get good care. But as long as you have a consultant who has the responsibility, I think most consultants will be more aware of things going wrong when they supervise than when they do the surgery themselves.
Yeah.
So for my own part, my two biggest complications I did as a consultant myself without any help from the resident. That was one thing. And the other thing, when it comes to the time necessary to do supervision work, I presume most of you in Norway has this time planning tool called GATT. And since I'm head of the department, I use it a lot. And it's a tool for frustration, but it's also a good tool to visualize that supervision takes time. So my plan is you have to put this into the planned tasks of every consultant and every resident to do supervision and have time for it. So if anybody asks me later on if, hey, why don't you produce as much surgery as you did last month? It's because I've been told to do this as well. And there's no more than 24 hours a day for anyone. So I think you have to be very specific that you set off time necessary for supervision.
Yeah. Just a quick comment about that complication part. Naturally, I agree, of course. But I think from a patient's perspective, if they haven't heard anything about there being a junior doctor involved in the procedure, this might be an alarming thing for them if they experience a complication. One of our participants in the latest course was himself a surgeon and been acutely ill for a few years back and had underwent surgery. He was stable enough that he had talked with the main operator in beforehand, and there was a complication. And later on, he experienced that there was a junior doctor who had performed most of the surgery. And he had reacted very strongly on that because he wasn't informed that this person would be in the room at all. So that's why we started discussing this in depth. So as I said, there's many arguments, just pro et contra to inform in depth, but I think it's at least important to have a strategy around this, how you solve this issue. Yeah.
I just have a short question to the audience. How many of you are scheduling time for supervision in the outpatient clinic? Oh, that's good. Only 2, 3, 4, 5, 6, 7. Yeah, not too bad.
So I'm David Stevens and work in Trondheim. And we had an interesting discussion at lunch today about, I think, some of the challenges that will arise with trying to implement the changes in medical education here in Norway. And one thing that I see as a difficulty here is exactly what the last question that Thomas asked was, how will we make supervision occur in a more appropriate way during the day? And I think it's wonderful that so many people are gathered here, because I hope that we can help solve some of this with a common format, instead of each clinic and each hospital trying to determine what is a unique solution. One thing that we've planned to do in the rheumatology department is add a half an hour of time to a single consultant physician, an overläge, at the end of the morning from 11:30 to noon, so that that consultant can be interrupted continuously during their morning, and hopefully not work through their lunchtime to catch up on their own work. And one thing that I thought was very interesting that you mentioned in the common presentation was about the different organization of the outpatient clinic with a parallel track versus a more continuous supervision. But for those of us who work with a parallel track where an overläge is seeing their own patients and leasläge are seeing their own patients at the same time, do you guys have any good recommendations for how we can solve that difficult challenge? Thank you.
Luckily, I'm not a leader myself, so I don't have to address this issue in detail, but the logistics needs to be in place. There has to be enough rooms, and you have to think about the outpatient schedule. Maybe the overläge should have a few less patients, so he or her is more available to see the lease whenever needed. But how to solve this in the practical way in all the hospitals in Norway, I don't know. Do you have any?
In our courses, we have discovered that some don't take any precautions at all if there's a new doctor coming. He just gets a full polyclinic list, outpatient list, and just do it. And if you don't survive 2 months, then you're not meant to be. And then you've got others that says, oh, we got a new doctor. We have to make sure that the senior doctor is not overloaded, so he could sit in on a few of the patients in the beginning to make sure he's quick to get better and can stay alive for most of the time himself during the outpatient clinic. So it's some departments are already good, some haven't thought about this at all, but I think it's very important for you to think that when there's a new doctor coming, we should take care of him or her to make sure we know the competency of that doctor and how to help this doctor progress so he or she is good enough in quite a short time. So we have more self-sufficient or a doctor that can work by himself. Yeah.
More competent.
More competent doctor, yes.
Hello, I'm Elin. I'm head of Regut in north of Norway, working with organizing the new education. And thank you for your talks. And I have a comment too. I was very happy to hear about when you talked about the culture for supervision and coaching, and how you had a model for how to do it. And if I heard you correctly, I thought it's important that we have a model because it shows that we have a culture for feedback. And we need that because not just for the junior doctors, but also for the senior ones who might just have arrived to work with us. They also need to know the way around and how you do it. And I would just like to remind all of us that most of the junior doctors will soon, if they're not already, have a permanent position. So we're not just teaching some students, we are developing our colleagues. And that should be an argument to take home to your leaders. It's our own folks. If we don't make them good, it's bad for us in the long run. Thank you.
Hello, my name is Stig Heier. I'm an orthopedic surgeon at Martina Hansens Hospital in close to Oslo. There is no doubt this whole program will take some time and resources, like Ingeborg said, and I guess most of the hospitals that are represented here are already going with red numbers. I'm working at a hospital. We can't present red numbers. So how are we going to solve this?
Yeah. Yeah, the other orthopedic surgeon who asked some questions earlier from Stavanger there, we just have to prioritize hard when the leaders use this GUT tool to plan ahead. Some rooms, outpatient clinics, operating theaters needs to be the program needs to be devised so that it's some air available to perform good supervision. We have to prioritize this, but the economy part and the production part is of course really important issues as well. So I think over time, with little change, we can get there. But yeah, I don't have the exact answer.
No. We should also think about this as an investment in the future, because the expectations to the healthcare is just increasing day by day. It's not good enough for an orthopedic surgeon to end up like Knut Harbo in 10 years, because you will have to outperform your role models in 10 years. That's how it is. And then we have to make sure we invest good and make sure we progress and get the best doctors ever, because that's the expectation, no less. It's an investment.
Yeah, my name is Sarah Gilani. I'm a resident at Aarhus and a part of the project that's been working on the competency-based resident program for the Norwegian healthcare system. And I'd like to summarize a few points that have been said here already, but were also taken up on this conference last year. That a lot of you who are in this room right now, you're head of different departments. You know what you need, you know what your challenges are, and you know what arenas you're supposed to work on. And that is your strength. You should sit down in your departments, find out where you're seeing the challenges and how you can work on them. Because last year we had the head of department in Vestre Viken internal medical ward, and he'd actually done this both on the economical aspect but also on the practical. And what he found out was that he could use his monthly or weekly regular hours for livsundervisning, as it's called in Norwegian, to do some of this teaching, supervising, following up his residents. Also, while I was doing my LIS 1, we had a specific supervisor, a senior doctor who knew the field, who followed each and every single one of the new residents. And he had the competency, he had the background, the information he needed to pass on to all those new residents. And the thing is, as a resident, we also need and want information, and not all of us are as good at asking. So if you have someone you know in your departments who can do this work, haul them in and try to make a program around your own ward, your own challenges, your own departments. At least that's my suggestion.
Hi, my name is Kristin Fagereng. I'm a resident in anesthesia in Stavanger, and I've noticed that it's a subject that hasn't come up yet, and I think it's one of the most difficult subjects in terms of supervision and guidance of residents, and that's when you come to an endpoint where you realize, or especially maybe the leader realizes, that the resident does not work, cannot function in this specialty, And I wondered if Sargent could elaborate on if she has any strategies or examples, or could say anything about how you define this endpoint and how it's possible to manage.
That's a very good question. Thank you, and a difficult one, and one that we're, working on at various levels in Canada. I think one of the strengths that we find about having competencies that are defined, and I think Jason will say more about this afternoon, is that you know what is expected, and what we have found in the past. For those residents that it gets close to the time that you think that they should be finishing their program, and you think, oh my goodness, they're not proficient enough, they shouldn't be doctors, but you don't have any data to support it. And so what we found is with competencies is that we know specifically what the residents need to be doing, and we need to be collecting data about that. And I think this may be another change for you as you move forward in competency-based education, is it's not just enough to give feedback in the moment, it's also required to record it, so that if a resident has passed and so that resident Chris that I gave you an example of really had passed and really could come to a diagnosis and implement a treatment plan, that then you would record that and that would be ticked off that yes, he is able to do this. But without that, it's very difficult. And so I would challenge you as part of the huge initiative that you're undertaking to think about how you might begin to document some of this resident progression as it's that data, that observational data, and the data about the conversations you've had with the resident that are needed for those really difficult situations. Right, do you have anything that you would like to add from your experience?
Well, it's always difficult when the residents or interns don't work, and I agree, you have to document what you've been talking about and how things are going. And there is this, I said earlier, we have to train how to take comments and how to give comments, because we're not so used to doing that in Norway. We're kind of frightened to tell things that aren't good. So I think maybe that's the culture we need to try to change. Mm.
Thank you very much. Excuse me, I had one more question. My name is Katinka Meirik. I'm representing the Norwegian Medical Association today. We get several reports from several specialities regarding guidance that is far too often with 1 hour a month. What can we fill this time with? I'm a psychiatrist myself, so I have no trouble using 1 hour a week for this. But this is, several specialities give these comments that they struggle using this time constructively. So I'm asking especially Ingeborg and Jens Axel, do you have any suggestions?
Yeah, and related to the last question, the guiding of Alice throughout his or her education has a lot of important themes like ethical issues that you are exposed for all the time, and whether you have chosen the correct pathway in your career, whether you're competent or not, like the bigger questions throughout the whole educational run. Mm. I think 1 hour a month isn't that much, so I think you need to be quite low on fantasy to not feel that 1 hour a month.
I think there are so much about being a doctor that 1 hour a month to talk about it isn't much at all. because when you're a fresh doctor, junior doctor, there are so much new things you have to discuss about both the progression and, as you said, the ethical aspects and everything else that, like the 7 roles for a doctor. What is our work? What is our profession? And that's a development because we're not finished professionals when we start our residency. So there are so many things just to guide us the whole way to become the senior doctor. And still there are plenty of things to learn when you're a senior doctor, so you're not finished getting tutoring, I think.
Yeah. Well, we're running out of time. I see there's one last question. Is it quick, Trine? Is it Trine? Yes?
Yeah.
It's so important that I take it in Norwegian. Og det felles kompetansemål. Vi kommer ikke til å ha kapasitet og ressurser til å ha gruppeveiledning og kurs på alle disse felles kompetansemålene. Mange av de kan tas opp i individuelle veiledninger, og i Sykehuset Innlandet så lager vi et årshjul eller 3-årshjul hvor vi dekker alle disse felles kompetansemålene, blant annet i individuelle veiledersamtaler. Det kommer til å få tiden til å gå. Takk.
Thank you very much. These contributions have been important to us, and thank you so much for sharing and for taking the time to prepare and to come all the way from Canada to Norway to enlighten us about the importance of feedback. Thank you very much, everyone.
Da har vi en liten pause frem til 13:30, og så har vi endret